Welcome to a deep dive tailored just for you. Today, we're stepping into, well, probably the most dynamic phase outside infancy, the preschooler years, ages 3 to 6.
Right. It's this amazing period where a child really shifts, from that kind of stumbling toddler to a much more sophisticated, school-ready little person.
A huge leap. So, our mission today.
It's really about translating the big theories, Piaget, Erikson, Kohlberg, into practical knowledge for pediatric nursing. We want to boil down those core milestones and connect them straight to interventions, things you can actually use.
Okay, so getting those critical facts ready for clinical judgment. Let's start with the physical side. Growth slows down, you said, but what does the typical 3 to 6-year-old actually look like, and what's going on inside?
Well, yeah, the growth rate definitely slows. We're talking maybe 4 to 5 pounds, 2.3 kilos a year. They tend to slim down, look more upright, more agile. Their limbs get longer relative to their torso.
Ah, so they lose that sort of toddler potbelly look and start looking more athletic?
Exactly, more coordinated. And internally, a really crucial piece is the myelination of the spinal cord finishing up.
Okay, and that allows for?
For bowel and bladder control.
Yeah.
Usually bowel control around age 3, and then bladder control typically by age 4 or 5.
Right. But you also mentioned their bones are still maturing, so more prone to injury even with that agility.
Precisely. Their musculoskeletal system isn't fully mature yet. They're trying out all these new skills, taking risks maybe, and yeah, they're more susceptible to things like overexertion or falls.
Got it. Okay, now let's pivot to the mind, which is, well, fascinating at this age. Piaget's preoperational stage, it's all about intense, but maybe not always logical thinking.
That's a good way to put it. It's fundamentally egocentric. They really can only see things from their own perspective.
We hear terms like animism giving life to objects. But what about transduction? How does that play out?
Yeah, transduction is basically faulty reasoning. They link one specific event to another unrelated specific event. So, like the example in the text, a child might refuse dinner because maybe their sibling got sick after eating earlier.
Ah, connecting two things that aren't actually connected causally.
Exactly. There's no real logic there, just association.
And fueling all this is that famous magical thinking, and of course the imaginary friend. Some parents might worry about that.
They might, but they really shouldn't. Magical thinking, the idea that thoughts are all powerful, is totally normal. It helps them, process the world.
And the imaginary friend.
It's actually a super creative tool. It lets them practice social skills, try out different behaviors, kind of work out scenarios without real stakes. It shows they can differentiate fantasy from reality.
Okay, so it's healthy. Now, how does this powerful imagination intersect with their developing sense of right and wrong? Let's bring in Erikson. What's the core psychosocial task here?
It's initiative versus guilt. This is huge. They're eager to plan things, start games, take the lead. That's the initiative. They feel great when they succeed.
But the guilt part.
That comes in if their plans kind of fail consistently, or if they're criticized too much for trying. They start to feel like maybe their ideas are bad. It's really delicate balance.
Yeah.
And it's where their conscience, the superego, really solidifies.
And that conscience links right into Kohlberg's moral stages. Where are they at?
They're solidly in the pre-conventional stage, specifically the punishment and obedience orientation.
Meaning
Morality is all external. Rules are followed basically to avoid getting into trouble or maybe to get a reward. It's not about abstract good or bad.
So that explains why lying might start around now. Fear of punishment.
Often, yes. Either fear of punishment or sometimes just, their vivid imagination blurring the lines with reality. Nurses really need to remember that their primary driver is self-interest at this point.
Right. Okay, let's talk communication. It just explodes, doesn't it? From maybe telegraphic speech at 3 to thousands of words by 5.
Oh, it's incredible. Around 2,000 words by age 5, using much more adult-like sentences. But sometimes that rapid growth causes a little hiccup.
You mean stuttering?
Yeah, what we call dysfluency. It's temporary. The brain's just trying to keep up with all the new language skills. It usually resolves on its own by age 8 or so.
So the advice for parents is just be patient.
Exactly. Slow down your own speech. Don't rush them. Don't make a big deal out of it. And crucially, remember, their communication is still very concrete.
Meaning no abstract concepts.
Right. If you're talking about something scary, like surgery, you need to be super literal and clear. Avoid euphemisms because their imagination will fill in the blanks, often with something way scarier.
Good point. Okay, motor skills. We touched on agility, but let's contrast a 3-year-old versus a 5-year-old. Gross motor first.
Sure. A 3-year-old might be pedaling a tricycle, walking upstairs, alternating feet. But by 5, they can probably hop, skip, stand on one foot for like 10 seconds. They're ready for more complex things, maybe swimming lessons, skating.
And fine motor. This seems key for school readiness.
Absolutely key. By 5, they can usually use scissors pretty well, copy shapes like a triangle, maybe write some capital letters, and draw a person with several distinct body parts. At least 6 is the milestone.
That dexterity really changes how they play, too, right?
Definitely. Play shifts away from just playing alongside others, parallel play, towards cooperative play.
Sure, actually working together.
Yeah, defining roles, making up rules, maybe building a fort together. It's the start of real socialization. And for therapeutic use, dramatic play is so important.
Role-playing, like doctor or house.
Exactly. It lets them act out anxieties, try on different feelings, maybe process scary experiences in a safe way. Their imagination fuels it.
Speaking of imagination, what about screen time? Big topic these days.
Crucial point for guidance. The recommendation is really strict.
Yeah.
Limit screen time to just 1 hour per day of high-quality programming.
Only an hour. Why so strict?
Wow. 2 main reasons. 1, to encourage physical activity. And 2, because with their magical thinking and vivid imagination, even seemingly mild, scary, or violent contents can become terrifyingly real to them. We need to protect them from that.
Makes sense. Okay, let's shift gears to direct clinical application. You mentioned unintentional injury is the leading cause of death. What are the absolute must-dos for nurses addressing risk for injury?
We have to be super specific and firm with safety teaching. Number 1, car seats. Appropriate forward-facing car seats or boosters until they hit the height or age limits, usually 4'9" or 12 years old.
Okay, what else?
Helmets. Bicycle helmets for any wheeled toy bikes, scooters, skates, whatever, even in the driveway, no exceptions.
Got it. Firearms.
If they're in the home, they absolutely must be locked up with ammunition stored completely separately, unloaded and locked away.
And water safety, even if they've had lessons.
Supervision is always required. Always. Drowning happens silently and quickly. Lessons help, but they don't make a child drown-proof. Constant vigilance is key.
Okay, critical safety points. Now, nutrition. We often see issues like imbalanced nutrition or risk for overweight. What's the key guidance there, especially around drinks?
Fluids are a big one. Too much juice or milk can totally kill their appetite for real food. So the limits are clear. 4 to 6 ounces of juice per day, max. And milk, maybe 16 to 24 ounces per day.
And beyond liquids.
Focus on nutrient-dense meals and snacks. And honestly, parental modeling is huge. Parents need to eat healthy foods themselves.
What about picky eaters? It's so tempting to just give them something.
I know, but resist substituting junk food. Offering high-calorie, low-nutrient foods just to get them to eat something reinforces poor habits. Keep offering healthy options patiently.
Right, setting those patterns early. Okay, last big area before we wrap up some common concerns. Preparing for school. What's the nurse's role in promoting school readiness?
We're looking at several things. Language development. Are they socially mature enough? Can they handle some structure? We also screen for risks like insecure attachment, which can impact school adjustment.
And when advising parents about choosing a preschool?
Look for places that actively build self-esteem. And crucially, ensure the program does not use corporal punishment. Spanking, hitting it, strongly discouraged. It's linked to aggression and other long-term problems.
Okay, so that brings us right back to discipline. If spanking is out and noted as least effective anyway, what should nurses recommend?
The most effective strategy for this age is timeout, but it has to be used correctly. Clear, consistent limits first. Then timeout is 1 minute per year of age.
So 3 minutes for a 3-year-old?
Exactly. In a boring spot, no distractions, no toys. It's a consequence, not a conversation. Gives them a chance to calm down without shame.
Okay. Now, sleep. That active imagination causes issues here too. Nightmares and night terrors, how do we help parents tell them apart?
This comes up a lot. It's vital guidance. The key difference is responsiveness. A nightmare happens later in the night during REM sleep. The child wakes up, they're scared, but they respond to comfort, they know you're there, and they usually remember the bad dream.
Okay, that's a nightmare. What about a night terror?
A night terror is different. It happens earlier, usually about an hour after falling asleep, during deep non-REM sleep. The child might scream, thrash, look terrified, wide-eyed, but they are not awake. They're completely unaware of the parent trying to comfort them.
And they don't remember it?
Nope. No memory afterward. It's way scarier for the parent witnessing it than for the child experiencing it. The best thing is just to ensure they're safe and let it pass. Don't try to wake them.
Wow, okay. That's a clear distinction. Any other common concerns? Lying? Masturbation?
Yeah, those come up With lying, we need to figure out why. Is it fear of punishment, or just that overactive imagination blurring fantasy and reality?
Hmm.
How you address it depends on the cause.
And masturbation.
It's typically normal exploration and curiosity about their bodies at this age, not sexual in the adult sense. The guidance is usually simple. Teach them about privacy, that it's something done in their own room, not in public. Keep it matter of fact.
Okay, that covers a lot of ground. From physical growth slowing down, that huge cognitive shift into magical thinking, developing initiative.
To the nuts and bolts of safety, nutrition, cooperative play, and handling those tricky behaviors like lying or differentiating sleep disturbances. We've really tried to link those theories straight to what you'll see and do as a nurse.
Recognizing these milestones of potential red flags before they hit formal schooling seems incredibly important.
It really is foundational. Addressing delays or risks early makes a huge difference.
So, to leave everyone with something to think about, we've talked about setting limits on nutrition, pushing physical activity, restricting screen time, using effective discipline like timeout. If we manage to get these pieces right during the preschool years, what's the bigger picture? What's the long-term public health impact of laying this foundation now, particularly thinking about preventing issues like adult obesity later on? Why is this stage so critical for lifelong health habits?
Definitely something powerful to reflect on as you head into your practice. Thanks for joining us for this deep dive into the preschooler.
Yes, thank you. And from the whole Last Minute Lecture team, we wish you the very best in your studies.